What if you could sit down once a week with a colleague who's a flat-out warrior? This colleague wasn't a stud in dental school. He struggled. He returned to practice in his hometown, an area once labeled by USA Today as the second worst place to live economically in the United States. And this very same colleague went on to establish an historically successful general practice known worldwide. What if you knew someone that wanted to take you by the hand and show you everything you need to know, from treatment planning to leadership, to maximizing your journey in dentistry, or just life? You ready to be inspired? Welcome to the Lionhearted.
Hi everyone, Dr. Steve Rasner. Welcome back to the Lionhearted Dental Podcast. Right now you're all in different areas. Some of you are on your way to work. As you say to me, you listen to me on the way to work on Mondays or whenever it is. And you're the reason I keep doing this. I shouldn't be, but I'm very motivated by the numbers of downloads. And they go up and they go down. The last couple of months, they haven't been the greatest numbers. And right now, I don't care because there's a few of you reaching me that continue to make me feel this is worthwhile. So here we go. Last week, at one point, I don't know if you heard last week, but I told you for the first time, I was in the early stages of developing a private group of dentists. I don't know how many I'll limit it to, like-minded, of perhaps 20, and this can be anywhere in the world. It doesn't have to be the US. And we are going to network monthly. You and I privately, you and I collectively as a group, to take your practice to the highest levels possible. And I'm pretty excited about it, although I have a lot of work to do. This, by the way, does not replace the live Lionhearted weekend that I have alluded to. That is a separate entity. And I've learned a lot about the way to provide a conference in 2023. The last time I did it was probably in the year 2000, 23 years ago. And there's many more dynamic ways to do it than I was thinking. See, you're catching me developing just like I'm trying to help you develop at your particular stage of your journey. I'm developing as a professional. And please keep in mind that my desire to do this has nothing to do with a financial way to create income. I am passionate about what I do. I am passionate about reaching you guys and hearing your success stories or your challenges. Either one, doesn't matter to me. And so I'm going to share with you something I shared at my last live lecture, which was in New Orleans about 2 weeks ago. At one point, I didn't start my lecture this way, but at one point in the lecture, I ran a slide by them and I had told them that over a period of several weeks, my practice had averaged 6 digits in collections and productions. And it was extraordinary. And a couple of those weeks were 3-day weeks. So I'm talking, like a couple weeks ago, I had $140,000 a week. And I'm not denying the fact, as I have told you, that I was definitely off in the months of November, December, certainly January and February. And that is one of the longer periods that I can remember in my tenure as a private fee-for-service dentist that it went on that long. And I would like to sit here today and give you excuses like, well, I had the surgery in December, which accounts, I didn't even work in December. So obviously, my production went down. And, I didn't get back till mid-January, and I wasn't ready to roll even then. And so it is partly true. But leading up to that, I also had slowed down because that's the exact reason I decided to go forward and have surgery, because I couldn't do what I was doing in anything in life. Of course, not just professionally in dentistry. But that's changing. I mean, I didn't allow them to schedule me any major surgeries, for example, until March. I would do maybe a single implant when it got to mid-February and things like that, because of the body posture that I know I take, that I utilize, depending on where the implant or extraction is. And I was afraid of bending over and everything. So, I've lightened up on that. So, but let's go back to what I'm trying to orchestrate here to you. Let's say I do have these 6-digit collection and productive weeks. How's that possible? It's me, one associate, and, just for clarity, I have my office in Vineland, New Jersey, and I have an office in Bridgeton, which used to be my only office. And out of that one office, we did well over 4 mil for years and years and years. And then when I was 50 or 52, I branched to a second office, not because because I was out of room. That may happen to some of you. It was a big decision. I literally did not have an extra foot in that office to expand anywhere. That's it. So I had to say to myself, is this going to be good enough for the next 15 years for me? And I decided it wasn't. And when I did all my vetting and what my possibilities were, I ended up with a new office, a building I bought, 5 acres of land, major highway, really, really terrific location. About 20 minutes at the most from my first location. And I've been fortunate to have a great associate in the Bridgeton office for all these years. But quite honestly, and she wouldn't mind me saying this, she's very much mom and pop when it comes to the array of skills. She doesn't do a lot of root canal, if any. Certainly doesn't do any surgical dentistry. And hence, the production over there went way down. It's $1 million a year practice. Okay. Still utilizes a lot of the protocols I give you, as in case presentation skills, sedation, et cetera, et cetera. So how is it possible to do these extraordinary weeks? Well, the answer is, number one, you have to have the right clinical skill set. So just bear with me, guys, because I don't think I can remind you enough, if you're not where you want to be, what it takes to be where you want to be. And one, obviously, is the right clinical skill set. And you're going to hear me, I'm not going to do it on this podcast, but over and over and over again, I can't talk enough about oral sedation. Let me give you a news flash here in New Jersey. They changed the requirements. They added from basic CPR to advanced life support. And that is not a little thing. Not unless you're EMT or you work in a hospital where you're familiar with all those protocols. So I'm literally in the middle of that right now. I mean, if they told me I needed an IV sedation license currently, I would do that too. That is how committed I am to that change, the impact that has on your professional life in every possible way. Even though you're really only dispensing the cocktail of pills I use, which is, as you know, triazolam, Benadryl, Atarax, and nitrous oxide. And if it's the first time you ever heard me say that, you need a lot more from me. So, do you do sedation at all? Why would you just let that out the door? It would absolutely, completely, it's the number one thing that would change everything about my practice, that I'm trying to get you to emulate at least a portion of it. Number two, this is it. I'm trying to get you to look in the mirror today and ask yourself, well, why aren't I doing that? I just took a course, but so much of it has changed, guys. It's online. I was online with a sedation course because that's how you take them today. We used to go to a live venue and take a day and a half, and you can still do that. You know, starting to work with a group called Rocky Mountain Sedation, trying to put something together for next year because I'm such an advocate of this. Please email me if you want any of this type of information at drrasner@aol.com. Dr. my last name at aol.com. I just can't break from that to Gmail. I don't know what's wrong with me. I just don't. Okay. And so, how are your I mean, really, if you are not getting the productivity in your office that you think you should have, in other words, you're just not getting big cases, or you're not getting any treatment plans. You're treating symptoms. You're treating single teeth. If that's the case, I'm almost 100% sure it is your approach to a new patient, meaning how do you go about examining a new patient, which I've covered in depth here and on all over the place in earlier podcast. And number two, what's the magic? Why should they come to you? Do they like you? Are you likable? Are you approachable? Do you have the significant other in the chair in the room? Yesterday, I had a patient in my office, 60 years old, really fit guy, train wreck of a mouth, wore an upper denture, prognathic, poor job of a denture that somebody had made. And he wanted fixed, all on. Not a giant part of my practice, by the way. And presented, and it lowers a train wreck too. He's going to lose all his lower teeth. And when he came, you know, I had, by the way, he was scheduled against a returning patient who indicated problems. Mistake. See, that's how much detail. It is like strategizing for me, like I've taught some of you, when we take teeth out. We're strategizing in that morning meeting that you heard me tell you so importantly that we've reignited in my office. And it has helped immensely reducing the stress of my day and the day of my staff. Absolutely has. And I ask every morning, do you see any potential landmines? Do you? And yesterday, they'll miss it. I'm telling you, they missed it. I missed it. And it was a new patient at exactly the same time. My schedule was fine. Like, you can't book a new patient if I'm in the middle of a big procedure. I'm sorry, and neither can you for you. That's extra work of your scheduling coordinator. Okay, it is. Sometimes in life we have to do extra things to be successful. That's why that job is so important. You can't just say, oh, a new patient called. There's an opening at 2 o'clock on Tuesday. No, you have to see what else is going on Tuesday. Doc's doing full mouth extractions. Can't be there. Doc's doing a guided surgery. Can't be there. It wasn't any of those yesterday. But it was up against at the exact same time a returning patient, which hadn't been there in 5 years, indicated multiple problems, front teeth missing. And hence, who do I go to first? I mean, as soon as you think like that, and as soon as you find yourself in that quagmire, then it was wrong. And I got to be honest, I was incredibly disappointed with my team because it wasn't like I say in that meeting, please look for me because I may be missing that. And I didn't say it. Really, the hygienist should have seen it. They're in that meeting. They see RP, it means returning patient. They see NP. We do that on purpose. Somebody should have caught it. So, you know, scheduling is very, very important. And that patient that I'm alluding to, which is why I brought this story up, did not come with his significant other. I'm dead. As soon as you have a patient say they're wearing a denture, they would like implant. As soon as they say they would like implant therapy, you have to really push hard for the significant other. Because if you don't, one of two things is going to happen. Either you'll lose the case because you actually go through and quote them, and they'll go back to their significant other, and nobody can appreciate you if they weren't in that room, of your sincerity, of your passion. You're just a quote they got. That's all it is. That's a bad, bad policy to not have the significant other there. And so you're going to say to me, which is legit, well, what do I do if they won't bring them? I'd rather you put the patient out 3 weeks when they could come in with a significant other than fill a spot that's open in your office in the next week when they can't come with the patient. They are telling you they have significant needs. We need them there. And I'm telling you, to me, and I think I'm one of the best case presenters you could ever find. If they're not there, it is unusual for me. If it's a $10,000 plus case, it is unusual for me to get case acceptance, which means I get paid. Very unusual. And they'll just act like they didn't say what they said on the telephone, which is, oh, I make my own decisions. I don't need my wife or my husband. I write the checks in this household. They're almost borderline offended that you asked them that. And it was not anything to be offended about, guys. 4 eyes, 4 ears hear a person better than 2. And we're not talking about coming in for a clean checkup because you go every 6 months and that's why you're there. No, you don't have to do it for that patient. Okay. And then I would just ask you, have you put any work into specific case presentation skills? So for example, and some of you, pardon me, have heard me talk about this. What if they come in, you see the x-rays, and you don't know this over the phone, but you suspect when you walk in that it's a terminal dentition. In other words, they're losing their teeth. We all get those. So what is your shtick? Do you show them pictures? Do you just speak eloquently about the options? Well, the terminal dentition is positively a place that you need 3D models to get your point across. And if you haven't heard me speak before about this, I'm talking about I have a bin next to me. It could probably be more attractive. I only have one. It's on wheels. The hygienist wheels it into my room. And in there is a denture mounted on an articulator, which I can't believe I even do this, but occasionally we've got them and we can sell them to you. You can make your own for free. Just make it a really clean, nice looking model, or ask your lab to do it. I don't care. I don't know what ours cost, but I got a lot of requests, so I made them. Okay. There is nothing more powerful than the patient in the chair. So you're saying, let me show you what a denture's like. I know you probably have seen a denture, but now you're up close and personal. Let's show you what a denture is. And I bring this over on the articulator. I take off the upper and I put it in her hand. This is not to intimidate them, put in the fear of God. It is to educate them. And it is alarming to many when they point to the plastic in the roof of the mouth and really see up, because it's a real sized, real case. And then I have the model that the denture came off of, and I show them, and I point to the palate. And I talk with absolute truth and passion, I'll say this. I'll say, listen, before I say what I'm going to say, because it's going to sound negative about a denture, a lot of people wear these successfully. It wouldn't be my choice. And there's not a doubt in my mind I'm giving you the right advice when I say to you, if you absolutely could afford in your world an implant retained set of teeth, then that's what you should pursue. But there's a tremendous difference, and we'll get to that. So I go back and I say, when you eat certain foods, I want you right now to picture a potato chip, ice cream, things like that. When I say that to you, I know it invokes a taste in your head, as you're envisioning this. And that's because sometimes all of us think about the crunching of a potato chip, for example, up against our palate, where we can feel the salt or the coolness of ice cream. Now, you can have those things with a denture. It's just you don't have that sensory effect. And I don't make a big deal out of it. You're not going to die from that. It's just, I want you to know where you're going with this. Okay? And then I'll show them the lower. And I'll say, this is worse than the one I just showed you, and tell me why. What don't you see on this lower model? And nobody ever gets it. I said, well, you don't see the tongue. The muscle that when you yawn, talk, swallow, raises muscles, ligaments, and pops your denture out. And I want to tell you, it is a rarity for me. If somebody comes in and they love their lower denture, which happened, I think, once during the Nixon administration in the late 60s. If somebody says that and they're happy, I don't talk them into anything. I don't. That does not happen often, so it's not really worth making this podcast, worth getting into the podcast. So I'm going back, and what I've explained to you in a long-winded process was, how are those types of weeks that I described to you possible? And it's the right clinical set. Because I can be, and you can be, incredibly productive, when the patient's on the regimen I give you. I took a sedation course Sunday night, and the doctor leading that course, I believe he was advocating midazolam liquid. Apparently some people give that as a sedation technique. And, and he mentioned that, you get a good 2 hours out of it. Well, 2 hours is not even close to being enough. I am sitting here looking you in the eye telling you that I do 4-hour cases multiple times a week. Maybe I'm just slow, but I don't think so. That's what a big case can take. I've got a case, I've done many cases this year, or a few cases this year, where they were in the chair 5 hours. And I've given them a second triazolam 3.5 hours into it. So I don't know of a better, and I have tried. I have worked with pharmaceutical companies, and maybe I was wrong. I thought maybe there is a better way. They have these wafers that are used in the practice of ophthalmic eye surgery that go under the tongue. Again, you get a nice initial quicker buzz than my protocol. The same with midazolam as well, but it doesn't last long enough. So that's the problem. So I would say one more thing about the right clinical skill. If it's not surgery, you would benefit from the marketing of oral sedation in your community. And if you don't do the surgery, I would highly think that you'd have to bring somebody in. Because the problem is this: when you bring in the new patient that came to you because it's not going to take long. It's going to take 1 year for you to become known as a sedation practice in your community. I am telling you, I can't be that wrong of a barometer for wherever you live. I, for 42 years, have attracted people from all walks of life, from all areas, that come in only because they know where this. Most of your colleagues will not do it. I just don't really understand it. And I guess good for us. More for us. Because if it wasn't that way, I wouldn't be able to talk to you about it like this. But if you bring them in and then you immediately refer them out to an OS to have their teeth removed, it kind of is the buzzkill. And I've never had to do that, so I don't know how I would work around that if that was the case. Okay, the second reason that those numbers are possible, and we're only going to do 3 today because I'm already getting long into the podcast, is a team that brings their A game every day. And that has become the hardest thing for me in the last couple years to deal with. The team. I never had it before. I don't understand how COVID could have permanently damaged the workforce here in the United States, but it feels that it has. In other words, staff calling out more than ever. Everything I've lectured about that I do not want in my team, calling out on a Monday, or regardless, like they might be there today, but they're well aware that tomorrow is a big day, and they call out. It's sickening. It's every week, and I never used to have this. I had somebody call out yesterday, flood in their basement. I'm not kidding. I know that happens. What were you going to do at home to help the flood? So here's what I'll tell you, and I really mean this. How do you nurture a staff today? If you haven't noticed from my demeanor, I generally am not Mr. Rogers. I don't yell. You don't have to do that. I'm just tough love kind of guy. So, and I will tell you today that is not the approach. You kind of have to be Mr. Rogers. It's laughable to me, but it actually works. So what does that mean with this generation? You can't give them enough positive talk. It doesn't matter if they just screwed up 5 days in a row. The second they do something positive, acknowledge it. I'm not kidding you. And of course, you have to pay them great. I always believed that the greatest pay was reserved for those with the greatest skill. Well, today, many of your colleagues have ruined that protocol because they're giving not only great pay right out of school, have proved nothing. I sound a little mad, right? Because I am. But they also give signing bonuses and just ridiculous things that have kind of ruined it. And I don't know if it's forever, but right now it's hard. So you can't even attract somebody for what used to be considered, when I say used to, pre-COVID, a reasonable rate for a middle level skilled dental assistant. And obviously, my practice of, if even one person calls off in the back, the clinic, it affects everything. And because it affects the associate. She has to have an assistant, of course. My master dental assistant needs an assistant, to help, because she takes things to the highest possible level before I come in. Well, you can't take off temps, clean up things by yourself very effectively. Keep, flushing with diluted bleach and tubeless it and all the materials that we use to follow protocols I've been taught. You can't do that alone. I would tell you, you can't give enough positive talk. I'll tell you, you have to pay great, whether you like it or not. And you have to employ bite your tongue patience. And my tongue is very bit up as we speak today. Holy smokes. I got a lot more to say about that. I will tell you also. The next step, of course, above positive talk and appreciation. And it doesn't cost a lot to do that. It just requires, I always believed that you had to earn everything in life. And that doesn't motivate a lot of people today. They do not want to hear about, they want instant gratification. And that's just the way it is. I know I'm probably going to generate a lot of hate mail on this, but it's just really how I believe. So positive talk, great pay, bite your tongue patience. And the last thing I'm going to tell you about, and I got many more to tell you next week on how to achieve those numbers. So how do you achieve them? If you don't have the right clinic, if you have a mediocre basic dental school range of services, you're never going to be able to reach lofty heights of a productive practice that enables you to do so many more things, not the least of which is giving back to your community. You'll never get it to the gear you need to be in if you go with basic direct restorative dentistry, no implant therapy, no extraction skills, no sedation skills. I'm sorry, that just doesn't work in a Lionhearted practice. You need something extraordinary. Now, maybe that extraordinary with you is you're a GP and you learn to do an amazing orthodontics or amazing endo. I do know GPs like that. I do. I've talked briefly about your team. And the last thing is to create and really create a relationship-based practice. And to do that, you have to meet with your team to define what that is in your office. It starts with being Walt Disney clean. That's part of a relationship-based practice. Nobody wants to have a relationship with a practice that feels, I mean, and one time dirty or not, I don't know, steril's the right word, could be the last time. So you have to, it's something that has to be exercised by everyone all the time. From the reception room all the way down to the clinic operatories. But besides that, it requires you doing something clinically gratuitous every day and something non-clinical every day if possible, which would be a card, a phone call. So we literally throw in free services. It's easy to do that. A re-cement of a crown that's not yours, or repair of a partial denture. They're actually heartwarming things to do. A consultation, an opinion. I don't charge established patients. You know, I wrote an article, Don't Lose a Patient Over a Cup of Coffee, because a hotel in Miami, Florida lost me 20 years ago. The Satai, you look it up. I think it's Satai in Florida. Beyonce used to hang there, all these glamorous people. And I paid a lot of money to stay there each night. And on the way to the airport one day, I said, hey, can I get a cup of coffee for the airport? And you and I know that lots of hotels, nice hotels, give you that cup of coffee. They said, sure. And they gave me a bill for $12 for a cup of coffee. Like a regular cup of coffee. And that was probably my last time with the Satai. We have a lot to talk about. I hope you like this forum today. I want to talk more next week. I'll make some notes about what else establishes extraordinary productive days, weeks, and months. A giant practice nucleus, the way you brand, even getting paid up front. Hope this helped, guys. Dr. Rasner, AOL.com. Please give me some feedback. Also, on the masterminding group I'm going to form, if that sounds appealing to you. I'm going to limit it. It could be 10 people. I don't know. That's not a sales tactic. It's me trying to be honest with you. See you next week on The Lionhearted.